All right, in this one, we are going to talk about the Curb 65 score. This will be a relatively quick lecture. So I posed a case on Instagram this morning, so maybe you had a chance to look at it. If not, I have it as one of the first slides, so we'll go through it. This lecture is not meant to be like a whole lecture on all the different causes of pneumonia. We'll talk about it a little bit, but when I talk about certain bugs down the line, we'll obviously cover the bugs that cause pneumonia. Okay, so this is a really high yield topic. You're absolutely going to want to know the Curb 65 score, what it means, in the next best steps if you're about to take step 2. So objectives, we're going to discuss how to calculate a Curb 65 score. What does it tell us? We're going to retouch on the Sepsis 1-hour bundle that I asked you in a separate case, in a separate lecture. We'll talk about empiric antibiotics in community-acquired pneumonia and hospital-acquired pneumonia. Which antibiotics do we switch to when the patient leaves the hospital? What's the pathophysiology of pneumonia? And then the most common organisms implicated. So this was the case I gave. We have a 72-year-old man presents to the emergency department with a 3-day history of productive cough, fever, and shortness of breath. On exam, he's alert but disoriented to time. His vitals show a BP of 88/56. His respiratory rate is 32. His temperature is 38.4. His SpO2 is 91, and his labs show a BUN of 25. So I want you to calculate his Curb 65 score and then tell me what the next best step in management is. So if you didn't get a chance to do it, think about it. Pause your screen. So what is the Curb 65 score? Well, the Curb 65 score is a clinical prediction rule that's used to assess the severity of community-acquired pneumonia. Okay, it's used to estimate the 30-day mortality risk. It's based on 5 things, right? The curb, okay, and the 65. The C stands for confusion, so new disorientation to person, place, or time. The urea, the BUN, is going to be greater than 19, so anything 20 or above. And again, why do I care about BUN in this case, right? Is this a kidney problem? No, it's a lung problem. Why do I care? So the BUN being elevated will tell me that the kidneys aren't being perfused as well, right? It's signifying some sort of acute kidney injury. The respiratory rate being greater than 30, the blood pressure is systolic being less than 90, diastolic being less than or equal to 60, and then 65 years or older, you get 1 point of each of these, okay? So the total score ranges from 0 to 5. Higher scores are associated with an increased mortality, and they kind of guide our decision making for whether we should hospitalize this patient. Should they just be on the general ward? Should they be in the ICU? Can we treat them outpatient? It's been validated in many cohorts. It's widely used in clinical practice. You'll probably for sure see it on step 2. They won't ask you to calculate the Curb 65 score, but they'll give you a patient with pneumonia. They'll give you enough information to calculate the score and ask you what's the next best step. And they'll say outpatient, inpatient, ICU, blah, 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 right? Here's the studies if you want to take a screenshot and throw them into Google if you want to read for yourself. So I just did this on open evidence. There's MD Calc as well. But basically, our patient has a Curb 65 score of 5. So if you calculated a Curb 65 of 5, good job. He hit all of these. And then if we look at what open evidence is telling us based on references, he's got a really high risk of mortality. So scores between 3 to 5, the 30-day mortality rate ranges from 21 to 60%. He has a high likelihood of requiring critical care interventions, such as mechanical ventilation and ICU, right? So scores of 3 to 5 are really bad, okay? We're going to stratify the scores in a second. But again, this guy kind of hit all of them. He had confusion. His BUN was above 19. His respiratory rate was above 30. He had low systolic and low diastolic. And then he was older than 65. So he got all the points. So how do we stratify the scores? Well, according to this invite from or the research article in the New England Journal of Medicine, patients with community-acquired pneumonia and a Curb 65 score of 0 to 1 can be managed as outpatients, okay? 0 to 1 outpatients. When they have a score of 2, 2 is when we start to consider hospitalization. And for most patients, it's probably going to be like a short hospitalization stay or a close observation, okay? And then those with a 3 to 5 should absolutely be hospitalized. And then the like kind of stratification to say, hey, does this patient need the ICU or not, takes into account more factors than just the Curb 65 score it can give us. But as long as if they have a score between 3 to 5, we're absolutely hospitalizing them. The scores of 4 to 5 are likely going to be ICU. So again, basically what's going to happen is if you get a Curb 65 score, you have a likely community-acquired pneumonia, you calculate the Curb 65 score and it's 0 or 1. Let's treat them outpatient, okay? If it's 2, we're probably going to say hospitalization. If it's 3 to 5, absolutely hospitalization. Those scores of 4 to 5, likely ICU. So your right answers on your board exams, 0 to, they're probably not going to give you right in the middle because that can be controversial, right? But they'll give you like a patient who doesn't have any of the curve 65 or just has one outpatient. And then they'll give you one that's like a 4 or 5, like the patient's really sick, that's ICU, right? If they give you one in the middle, just say hospitalization, and that will be the right answer. They probably couldn't have, if they gave you like a curve 65 score of 3, it would probably be unfair for them to give you hospitalization and ICU because now you're kind of getting into murky waters there. So hopefully that makes sense. Again, 0 to 1 outpatient, 2 likely hospitalization, 3 to 5 definitely hospitalization. Those scores of like closer to 5 definitely think about ICU. So from a previous lecture, do you remember what the sepsis 1 hour bundle is? If you watch my lecture called The Rash That Wrecked the System, I go into this. So pause your screen, see if you can recount it. So the sepsis 1 hour bundle, these are the things we're going to want to get within 1 hour of suspected sepsis. We're going to get a lactate, right? Because it's a decreased perfusion of blood flow to my different organs. Again, I go into the pathophysiology of sepsis in that lecture, so I'm not going into it now. But we can get the lactate and we can trend it, right? Are they getting blood perfusion to the organs? Yes or no, right? And then we can trend, is the lactate going down, right? Like it should, or is it staying the same or actually going up? Is this getting worse? We get a blood culture so we know what bacteria we're dealing with or which pathogen. We start empiric antibiotic treatment. We usually start IV lactated ringers at 30 cc's kgs per hour. We could potentially do 0.9% normal saline. I go into why lactated ringers is preferred by the Surviving Sepsis campaign of 2021 in that Rash That Wrecked the System lecture. So go watch that. And then we'll start pressors. Norepinephrine is our pressor go-to if the mean arterial pressure is less than 65. Again, that's 2/3 times DBP plus 1/3 times SBP. Again, I go into why norepinephrine and maybe not epinephrine in that same lecture. So again, sepsis 1 hour bundle, the things you're going to want to order within the first hour. I also, in that other lecture, I go into the usefulness of ProCal and the ADAPT sepsis trial that was brand new. So please watch that lecture. It was really helpful. It will be helpful for you. So I wanted to bring this up to the 2021 Surviving Sepsis Guidelines, talk about albumin a little bit. So our initial fluids are going to be our crystalloids, right? Lactated ringers or 0.9% normal saline. They're going to be the best for quick resuscitation in sepsis, septic shock. When to add albumin based on these guidelines, we consider it if we're going to need large volumes of crystalloids, and if we've given large volumes, but we still need fluid resuscitation. Because I can give a smaller amount of albumin that's going to do a better job than giving these large volumes of crystalloids. Because again, the albumin is going to suck fluid into the intravascular space, right? It's very, very high on oncotic pressure. So albumin, it may improve the mean arterial pressure, it may improve the filling pressures, and it may improve fluid balance, but it's never proven mortality benefit over crystalloids in septic shock. That's usually why it's not our go-to. It's also very expensive, and again, like it doesn't have this mortality benefit. It has been linked to like some anaphylaxis, but again, it doesn't have this mortality benefit, so it's used selectively. So again, initially we use lactated ringers or 0.9% normal saline, 30 cc's kg per hour. We can add albumin if we have given large volumes of crystalloids, but there's still ongoing fluid resuscitation is needed. Albumin may improve the mean arterial pressure, the filling pressures, the fluid balance. It does not have proven mortality benefit, and it's very costly. So again, stepwise, I give the fluids. If that hasn't worked, if the mean arterial pressure is still less than 65, give norepinephrine. We usually start at like 2 to 5 micrograms per minute, and we can kind of titrate up. If that still isn't working, then we can consider albumin based on these guidelines. So my next question for you is, which antibiotic should be started for community-acquired pneumonia and the patient's hospitalized versus hospital-acquired pneumonia, and obviously the patient's hospitalized? So pause your screen, think about those. So these are from like the Infectious Disease Society of America guidelines. For community-acquired pneumonia and we don't have MRSA or Pseudomonas risk, we usually start a beta-lactam plus a macrolide. So your classic example is ceftriaxone plus azithromycin. We can also use solo therapy, monotherapy with just a respiratory fluoroquinolone, something like levofloxacin. So again, your classic answer on your USMLE step exam will be something like some beta-lactam plus a macrolide, so ceftriaxone plus azithromycin is the classic example. They could just give you levofloxacin as well. Okay, this is going to cover strep pneumo, some of our atypicals, and respiratory flora, so it's a great combination. If the patient has hospital-acquired pneumonia, now we need to start thinking about Staph aureus and Pseudomonas. So we need to give an anti-pseudomonal beta-lactam, something like piperacillin tazobactam. Again, we have those campfire mnemonics, like classic drugs that are really good are going to be these anti-pseudomonal beta-lactams, like piperacillin tazobactam. Obviously, like carbamenapenes, aminoglycosides, monobactams can work. Polymyxins here and there, fluoroquinolones, kind of things like those. But really, like these anti-pseudomonal beta-lactams are like some of the go-tos. Cefepime is a really good cephalosporin that's also got great activity against Pseudomonas as well. And then we're going to add MRSA coverage so we can give vancomycin, linezolid, could be some of our go-tos, right? Vancomycin is probably going to be the go-to. And then we need to target these multi-drug resistant pathogens, including MRSA and Pseudomonas. So again, community-acquired pneumonia, we don't have any risk factors for MRSA or Pseudomonas. MRSA, like living in a like underserved area, like kind of like a more like if the patient's like homeless or they're living out on the like in a third world country and they just moved to America, that could be risk factors. If they have a history of being around people who have been colonized by MRSA, right? Those are other risk factors. Pseudomonas risk, one of the biggest ones is going to be diabetes. So we'll give these patients beta-lactam and a macrolide or a respiratory fluoroquinolone. If they've got hospital-acquired pneumonia and we have a strong suspicion for Staph aureus or Pseudomonas, we're going to start a anti-pseudomonal beta-lactam, and we're going to add MRSA coverage, likely with Vanco. Okay, this was a brand new study from 2025. It looked at almost 13,000 hospitalized adult patients with community-acquired pneumonia. They looked at the basically this SUCRA score. The higher the values indicate a greater likelihood of treatment being the most effective. Okay, so looking at 13,000 patients, this was like brand new. They found that clinical failure, trovafloxacin had the best score. Okay, bacteriological failure, clarithromycin plus ceftriaxone had the best score. Mortality going down, amoxicillin clavulanate had the best score. The lowest risk of adverse events, doxycycline. The lowest risk of GI events, again, doxycycline. And then treatment discontinuation, ciprofloxacin was the best. Again, guidelines are going to be these. Okay, so what they're going to test you on USMLE step 2 is going to be these for sure. Okay, absolutely know these. I'm showing you this brand new study because maybe in the future, in the next couple of years, the guidelines may change to kind of reflect this new data we have. But as of now, this slide 9, this is your go-to. Memorize this, understand it for USMLE step 2. Again, the beta-lactam macrolide, really good for strep pneumo, atypicals, respiratory flora. Anti-pseudomonal MRSA, we're covering the multi-drug resistant pathogens and MRSA and Pseudomonas. Okay, always understand the why. So then switching to outpatient, right? If we have a patient who had pneumonia, we treat them in the hospital, and now they still have to finish their course, but we're switching them outpatient, right? We don't need to keep giving them IV drugs. They can take oral. A New England of Journal Medicine review, you can find the DOI here. It showed that in healthy adults, less than 65 with no recent antibiotics, obviously other than this hospitalization, amoxicillin, doxycycline, or macrolides were really effective. This review says to avoid macrolides by itself in the United States because the pneumococcal resistance is over 30%. So you have a healthy adult, got hospitalized for pneumonia, they're less than 65, they haven't been on antibiotics recently, we can switch to amox or doxy, likely in the US. If they have comorbidities or recent antibiotics, like a lot of our patients who end up getting hospitalized will, we prefer amox clavulanate. We can add on doxy or macrolide. So it'll be amox clavulanate plus doxy or amox clavulanate plus macrolide. If the patient has a beta-lactam allergy, right, the step always loves asking these, we can give a respiratory fluoroquinolone. There are some weirder kind of drugs that they're not going to test you on. I just put those in there because their review article mentions them. So I wanted just to be complete. But again, we had a patient who had been hospitalized for community-acquired pneumonia. We're switching them outpatient. We can give them, if they're healthy, they're less than 65, no recent antibiotics, amox or doxy. Likely avoid macrolides in the US due to pneumococcal resistance. If they have comorbidities or were recently on antibiotics, we like giving amox clavulanate plus doxy or amox clavulanate plus macrolide. We can also give them just a solo respiratory fluoroquinolone. Okay, our goal is to target strep pneumo and atypicals and minimize the resistance development. So just for like our step one folks and for other people, just to remind ourselves of what actually is the pathophysiology of pneumonia, I really simplified it here, but the infection route is really going to be microaspiration of these airborne oropharyngeal pathogens that are then going to make their way down to the alveoli. Normally, they shouldn't, right? There's normally all of our defense systems, right? We have our cough, we have our mucociliary clearance, we have macrophages, right? There's some sort of defense. Maybe if the patient has an underlying inflammatory condition, they have underlying comorbidities that are damping down their immune system that allows these airborne pathogens to get in. We can then get inflammation. These pathogens seed the alveoli. They stimulate our whole immune response. They will then cause inflammation of the alveoli and the interstitium of the lung. This can lead to gas exchange disruption. So the alveoli fill with this exudate, right? All the pus basically from the neutrophils, all the inflammatory materials, and that impairs ventilation. So remember, I'll do a whole lecture on this, but we have two different types of VQ mismatches, right? V stands for ventilation, Q is perfusion. In this case, the patient's blood is still being perfused, but they have a problem getting oxygen to that blood, right? So that's a shunt. That's a problem with the alveoli itself. If it were the other kind, right? If the alveoli were totally patent, was totally able to get oxygen through, and blood is getting cut off for some reason, right? Maybe a pulmonary embolism. That's called dead space. I'll go into much more detail whenever I do that lecture. That can be a whole lecture on its own. So again, we get infection via aspiration. We have some sort of defense failure. We cause inflammation of the alveoli due to the pathogens invading. It can cause VQ mismatch via shunt or cutting off oxygen getting to the blood. And then there's different types, right? We can have lobar pneumonia, where it's a consolidation of a whole lobe, bronchopneumonia, where you have patchy inflammation around the bronchioles, interstitial, which would be atypical and it will affect the alveolar walls. And then we can have miliary, where it's diffuse tiny foci, often from hematogenous spread, classically TB. So one of my last questions for you are, what are the three most common causes of, I should have said, bacterial pneumonia in the United States? So think about the three most common causes of bacterial pneumonia. So those are going to be strep pneumo, which is described as a gram-positive diplococci. Definitely need to know that one for step one. Haemophilus influenza, gram-negative coccobacilli, and Staph aureus, a gram-positive cocci clusters, coagulase positive. For you step two people, you're probably like, oh, I don't need to know that. Yeah, you do. I would for sure know these three. If you're going into your step exam, those are easy points if you know your bacteria and how they're described, right? Step one, money, right? That's going to be a decent portion of your exam. Step two, I would absolutely still know them. All right, one final word, just because we talked about strep pneumo. We have these beautiful strep pneumo vaccines, right, in children less than or equal to 5. We can do the PCV15 or the PCV20. It's a 4-dose series. We can give an additional dose of the polysaccharide if they have a high risk, like asplenia or a cochlear implant. Adults that are greater than 50 or a high risk, 19 to 49 years old, can also get that additional dose. If they've never gotten a pneumococcal vaccine, we can give 1 dose of PCV20 or 1 dose of PCV15 and then the PPSV23 1 year later. If they were previously vaccinated, but they didn't finish their schedule, we can tailor their schedule based on their history. So again, children less than 5, they'll get PCV15 or 20 at a 4-dose series. If they need an additional dose because they've got a high risk, right, we can give another dose of the PPSV23. That's also the same for adults greater than 50, or if they're high risk between the ages of 19 to 49. So things like smoking, right, COPD would cause an increased risk. No prior pneumococcal vaccine, 1 dose of PCV20 or 1 dose of PCV15, and then PPSV23 1 year later. So that's what I've got. We talked about a lot in a less than 20 minutes. So we talked about the CURB-65, how to calculate it, what it means. We talked about empiric antibiotics for both community and hospital-acquired pneumonia. We talked about the sepsis 1-hour bundle and the surviving sepsis 2021 guidelines talking about albumin. Again, go watch my rash that wrecked the system to learn more about all of that. We talked about this brand new 2025 study showing different antibiotics that we could potentially use. But remember our guidelines, okay? We talked about the pathophysiology of pneumonia and the most common organisms. So a lot of information, digest it, and then apply it. All right.